Good evening, respected professor, and good evening, my dear students. I welcome you all to another session of RISA DNB online academic activities today. Today we have RISA session with theory questions discussion. I would like to invite the first presenter today, HIV and anesthesia.
Good evening, sir. I'm Dr. Juby from SIMS. I'll be presenting on HIV and anesthesia. So I'll be discussing on the topics like introduction, clinical staging, modes of spread, systemic involvement, treatment, and anesthetic management. So HIV is a single standard RNA virus of lentivirus subfamily of retrovirus. It is divided into two classes like HIV-1 and HIV-2. It predominantly affects the CD4 T cells and progressively destroys them. Coming to clinical stages, it is divided into 4 stages. First is asymptomatic, where patient does not have much of symptoms. They generally present with a persistent generalized lymphadenopathy. In mild symptoms, patients present with moderate weight loss of less than 10% of the body weight with recurrent upper respiratory tract infection, viral or fungal or skin infections, or oral or skin lesions. In the third stage, that is advanced symptoms, patients present with severe weight loss of more than 10% of the body weight. They can also present with chronic diarrhea, persistent fever, oral lesions, pulmonary TB, severe bacterial infections, anemia, neutropenia, or thrombocytopenia. In severe symptoms, that is AIDS, acute immune deficiency syndrome, patients present with wasting syndrome, that is weight loss of more than 10% of the body weight, wasting or body mass index less than 18.5, chronic diarrhea, persistent fever, encephalopathy, and nephropathy or cardiomyopathy, recurrent bacterial infection, opportunistic infections, or malignancy. Coming to the next topic, modes of spread. The most common modes of spread is the sexual contact, that is 60 to 70%. Next is from mother to child, around 20 to 30%. And 3 to 5% of spread is through blood transfusion. IV drug use 2 to 3%, and through needle stick injury around 1%. Coming in brief about the systemic involvement of the HIV infections. Coming to each systems, cardiovascular system, HIV virus have high affinity for myocardium. It can cause LV dilatation, cardiac dysfunction. 1% of the patients can present with pulmonary hypertension. Drugs, especially protease inhibitors, it can cause premature atherosclerosis. So patients can have diastolic dysfunction and can eventually lead to heart failure. 25% of the patients can present around with pericardial effusions, and they also can have, because of the other opportunistic infections and related diseases, patient can present with myocarditis in advanced disease. HIV is actually it's trophic for vascular structures, so patients can also present with an aortic aneurysm or aortic dissection. Coming to pulmonary system, both upper and lower airway is affected, maybe due to opportunistic infection or primarily due to HIV or associated malignancy or due to a side effect of drugs. Complications of respiratory failure, patient can have pneumothorax or a chronic pulmonary disease. The Kaposi sarcoma, lymphoma, all can present with a massive hemoptysis. HIV can directly affect the lung tissue. It can cause a destructive pulmonary syndrome, which is similar to emphysema. One of the common opportunity infection is PCP pneumonia, which is usually seen when CD4 count is less than 200 cells per millimeter cube. It has now decreased due to the heart therapy, which has chest X-ray finding of bilateral ground glass opacity, which is also seen in CT. Coming to CNS manifestations, HIV enters the CNS early in the course of infection. So CNS can be a reservoir of HIV. Patients can have a focal cerebral disease complicating AIDS, either maybe due to cerebral toxoplasmosis or primary CNS lymphoma or progressive multifocal leukoencephalopathy. Acute CVA is also common, which is coming as a complication of heart therapy. Meningitis can occur due to cryptococcal neoformous HIV or due to TB bacillus as an opportunistic infections. Increase in ICP can be either due to infectious cause or intracranial mass. Patient can also present with seizure or encephalopathy. Peripheral neuropathy is also common. And in advanced disease, patient can come with autonomic nervous system dysfunction. Coming to GIT, patient can present either with a difficulty or pain in swallowing. There can be delay gastric emptying time, and there can be patient can have a diarrhea due to electrolyte disturbances. And other GIT problems can be like pancreatitis and hepatobiliary impairment. Coming to endocrine and metabolic system, patients can have in later stages, patient can have adrenal insufficiency, which can be more serious complication of HIV. So random measurement of cortisol levels and tests for adrenal stimulation is required. And coming to hematology, hematopoietic system is widely affected. Most early finding is anemia. Within 2 weeks of HIV infestation, patient can present with lymphocytosis. And later on, when assessed disease the progress, there can be bone marrow involvement, which can be secondary to HIV or due to secondary to opportunistic infections, which can present as leukopenia, lymphocytopenia, or thrombocytopenia. And they are also prone to hypercoagulable state or coagulation abnormality. Coming to renal system, renal disease mainly secondary to HIV infections, or it can be due to viral hepatitis or associated drug use or heart therapy. Mainly it is seen with protease inhibitors, which will lead to acute tubular necrosis or nephrolithiasis. Nephrotic syndrome is also noted, and HIV associated nephropathy can lead to end-stage renal disease. Coming to treatment part, treatment of HIV includes the following. One is antiretroviral drugs and treatment of opportunistic infections, avoidance of alcohol and smoking, psychosocial counseling, and nutritious diet. In short, about antiretroviral drugs and the side effects, which is important to us. The drugs are divided into, first is the reverse transcriptase inhibitors, which include the nucleoside and the non-nucleoside inhibitors. In that, nucleoside analogs, example zidovudine, it can produce marrow suppression, myopathy, and it can inhibit cytochrome P450, about which I'll be talking later also. Lamivudine, it is quite well tolerated, but patient can present with the peripheral neuropathy, diarrhea, headache. And other drugs like stavudine, it can cause peripheral neuropathy. Tenofovir can produce renal toxicity. Didonesin can cause diarrhea and peripheral neuropathy. Non-nucleoside inhibitors, efavirenz can produce a dizziness and it can also cause teratogenicity. Nevirapine can produce rash or it can also induce a cytochrome P450. Protease inhibitors like indinavir can produce nephrolithiasis, inhibit cytochrome P450. Sakinavir can produce diarrhea, headache. Again, it can inhibit that cytochrome P450. Ritonavir can also do the same as well as elevate the triglyceride level. Fusion inhibitors like enfuvirtide, it can produce injection site reactions, headache, bacterial pneumonia, etc. And other drugs with opportunistic infections like TB will give anti-TB drugs. The side effects related to them are also seen. Coming to anesthetic management, anesthetic considerations, preoperative, intraoperative, and postoperative management. Preoperatively, we have to have a multi-system and multidisciplinary approach. History to be elicited properly to see if there is any systemic involvement involving the clinical or subclinical manifestation of any cardiac, pulmonary, neurological, renal, or hepatic disease, which I have described before. ASA class, if we say it is coming under ASA 2 if it is HIV without any evidence of immunocompromise. It comes under HIV, ASA 3 or 4 depending upon the severity of the disease. And all patients should always be considered a potential source of disease transmission. And in patients who are not on any antiretroviral therapy, starting a therapy immediately before the surgery is not indicated. Coming coming to the investigations, all the routine blood investigations, including the total differential count, blood grouping platelet, tests for hepatic and renal dysfunction should be done. Anemia with undue tachycardia usually associated with HIV infections. We need ECG echo, pulmonary function test, arterial ABG, because around two-thirds of the HIV patients will suffer from respiratory diseases. Chest X-ray, ECG. If demyelination is suspected, look for MRI spine. Opportunistic cerebral infections like aspergillosis may be detected by MRI or CT, but is not commonly indicated. IV access, other considerations, IV access may be difficult in IV drug users. Coming to intraoperative management, no specific anesthesia technique is preferred. And all the routine monitors should be connected. Some patients, the advanced disease patients are prone for autonomic neuropathy. So invasive monitoring is also advised. And if patient is having endocrinological dysfunctions, we give steroid supplementation. When we give GO, the risk for immunosuppressions is high compared to regional anesthesia. It can start from immediately after surgery till 3 to 11 days post surgery. All the other considerations like oropharyngeal and esophageal pathology, because of the oropharyngeal or esophageal pathology, they can be prone for difficult intubation, or there can be difficult risk of aspiration. And if patients have any risk of neuropathy, careful positioning should be done. Anesthetic drugs may interact with the antiretroviral drugs. Efficiency and toxicity of antiretroviral drugs can be affected, and these drugs can also affect the absorption and distribution, metabolism, and elimination of anesthetic drugs. The pharmacokinetic interaction due to liver enzyme induction or inhibition, particularly due to the cytochrome P450 enzyme. This protease inhibitors and NNRTI most commonly are implicated in this. Our drugs like etomidate, atracurium, remifentanil, desflurane does not have any interaction. They are quite safe to use. Regarding scoline, if there's patients has spinal cord involvement or a peripheral neuropathy, it is better to avoid scoline. Coming to opioids, effects of fentanyl is enhanced by ritonavir due to both liver enzyme inhibition and induction. Enzyme inhibition reduces the fentanyl clearance, and enzyme induction will increase the metabolism to active metabolites. Benzodiazepines, secondary can inhibit medazolam metabolism. Coming to calcium channel blockers, it may have enhanced hypotensive effect due to enzyme inhibition. Coming to local anesthetics such as lignocaine, it may have increased plasma levels due to enzyme inhibition. Neuromuscular block effect may be prolonged. A word about regional anesthesia. Regional anesthesia, the presence of HIV infection is not an absolute contraindications to regional anesthesia. But related contraindications are like myelopathy, any vertebral or spinal neoplasms, any CNS infections, or coagulopathy. And intraoperatively, regarding blood transfusion, there is evidence that allogenic blood transfusion into the HIV infected patients can lead to transfusion related immunomodulation. So thus, it can increase the HIV viral load. So blood should be only transfused where it is unavoidable to maintain the patient safety. And adequate pain management should be given. And a word about preparation of a theater and the personnel. In case of HIV, infection control preparation, including the universal precautions with gloves, aprons, and visors should be done. Sharp object collection devices with appropriate sharp handling. Staff should be fully aware of the protocol in the event of occupational exposure. That is, rinse and wash the affected area with soap and water. Recipient lab tests like HIV, acute hepatitis panel. Determine infectious status of the source. Then availability of post-exposure prophylaxis to be started as early as possible following the accidental exposure, ideally within 1 hour of exposure. It includes hepatitis B, immunoglobulin hepatitis B vaccine, achieve early identification of chronic hepatitis C, HIV post-exposure protocol with 3 or more antiretroviral drugs if non-HIV positive donor or high-risk patient, or with 2 or more antiretroviral drugs if low risk. These antiretroviral drugs are given for 4 weeks or until the source person is found to be negative for HIV. Follow up with counseling and HIV testing for at least 6 months post-exposure. Tests should be done as baseline, 6 weeks, 12 weeks, and 6 months. Coming to perioperative considerations for patients with HIV, minimize interruptions in antiretroviral therapy as possible to diminish the drug resistance. Consider drug interactions with ARV with use of drugs affected by hepatic enzymes inhibition or induction. Strict aseptic technique to be exercised. The anesthetic plan thus should be tailored to the individual patient and type of surgery as appropriate. Thank you, sir.
Very good. That was quite an exhaustive presentation. And you heard almost all the points. For the easy remembrance sake, you remember 3 things, triple things. One with the disease process, second with the patient's disease, how it affects the patient. So HIV, once patient contracts, there are 3 stages. Some books say 4 stages also. One is the first, after the virus enters the body of the affected individual, by the roots on the what she explained, like abnormal sexual contacts or by drug abuse, by intravenous method, or from mother to child, or blood transfusion. Do you know any history where blood transfusion caused HIV in a very, very popular athlete or a player in USA long back? Have you ever studied the history of this disease? Anyone of you? Who presented now? Tina, huh?
Juby, sir, from SIMS.
Ruby. Did you read about any history?
Oh, sir.
There was one doctor, one player called Arthur Ashe who played in a popular tennis player. He had a transfusion for some accident, and after about 10 years, he developed florid AIDS and died of that. So he was the person who became a champion to propagate that AIDS is a deadly disease. It can be very fatal. So he started a foundation against AIDS to help the patients suffering from AIDS. So when the patient gets infected like that, initial phase is like a just some simple flu, some body ache, fever, and cold. Although most of the time it is not detected at that stage. Nobody will be thinking that the patient has contracted HIV. So it is passed on as a simple flu, and then the next part is the dormant part. It is a plateau phase where it does not show any clinical evidence of any involvement. That may be quite for a number of years, 10 to 15 years also. And finally, if it has not been identified and not if the person's immunity is not strong enough, then he succumbs to that as the third stage where it becomes completely involving all the systems as she mentioned into what is called AIDS, acquired immunodeficiency syndrome. Okay? So these are the three stages of this particular disease. One is the seroconversion stage, which mimics a flu, viral flu. Second is a dormant stage. Third is a very florid AIDS end stage. And in this last AIDS stage, some books say it's a milder version, some books say it will have a very severe version. So they classify into 4 stages also, but ideally you can remember the 3 stages. Then the problems that happen to the patient again can be remembered as 3. One is the disease per se, the HIV infection per se produces a lot of problem. Second, once you identify the disease and start treating it with antiviral drugs, these antiviral drugs have very potential toxic drugs. So they cause their own side effects. And the third thing is once the patient immunity is down, then he contracts opportunistic infections, which can dominate and which can produce a lot of problem to the patient. So the disease-wise, there are 3 stages. Effect-wise, there are 3 things. One is the disease per se causing the effects. Second is the antiretroviral therapy causing effects. Third is the opportunistic infections causing the effect on the patients. So if you remember these 2 triplets, then you will be able to elaborate and write all these things in the exam. And I don't know how many of you are well versed. Dr. Ruby, you said about CD4. What is that CD4?
CD4 count, we check to assess the severity of the HIV infection, sir.
So what is the expansion of CD?
Cluster of differentiation, sir.
Cluster of differentiation, and which part of immunity spectrum it belongs to?
A T cell helper cell immunity, sir.
T cell, helper cell, that is associated with that. But under what pathway it comes? What are all the pathways of immunity? There is an innate immunity which have 2 pathways, isn't it? One is the classical pathway, the second is called the alternate pathway. Okay, so this comes under alternate pathway, the cluster differentiation or CD. There are how many CDs are there? Idea? There are up to 24 CDs. Okay, but the first 9 or 7 is very important, and they help in preparing the antigen for opsonolysis or destruction by combining with them and producing what is called antigen presenting cells for the macrophages and the other cells to destroy them. So they come under the alternate pathway category, and their count is very important for immunity. So if the count gets reduced, then the infecting virus becomes very dominant, and then it causes. Why it is called a retrovirus? You said it is the infection is caused by a retrovirus. What is the normal mechanism of any viral infection to become fold into a host body and then the multiplication? How does it happen?
The viral DNA integrates with the host DNA, sir.
Yes, very good. Then
Here in a retrovirus, there is the use of reverse transcriptase enzyme through which RNA becomes DNA and it gets integrated into the host cell.
very good, very good. So normally it doesn't go back in the reverse way. The messenger RNA joins and produces directly DNA. Here the reverse happens, and then there are proteins which are produced which try to become more active viral. So they remain dormant for a long number of years. That is the reason why the plateau phase, where there are no symptoms and patients don't, because they don't have any symptoms, they are not aware that they have contracted HIV. But if you take, so how do you identify the disease during the plateau phase when there is no symptoms?
P24 assay, sir.
Very good. And then also viral load, you can check for the viral load and the assay. So these are the methods by which you have to know. And sometimes this universal precaution itself is asked as a short note question. So it is you have to write a little more detail about that universal precaution. And in that she mentioned only about hand washing, apron, and gloves, mask, and all that, which we normally do. But here you have to mention about double glove wearing. Once you know you are dealing with a HIV patient, you must wear double glove, and you must be very careful with handling all the any liquid emanating from the patient who's contracted HIV, like blood, peritoneal fluid, pleural fluid, CSF, urine, all the fluids that are coming from the infected patient should be discarded or collected safely and discarded. Disposal is very important. The second thing is when you use anesthesia machine for the HIV patient, you must use all disposable circuits, and the soda lime, everything should be changed after that person has been anesthetized if you have given GA with the machine. And if you have used the laryngoscope, that should be properly washed and then autoclaved and sterilized if you are using a reusable laryngoscope. And all sharp needles and others, knife and other objects that you are using should be totally disposed of in the proper way. And patient to patient contact and the anesthesia healthcare providers both are at risk. So once the patient is introduced, he should be taken up as the last case in the list so that the other patients do not get infected through him. So always post this patient as the last one, and then clear the even the linen on which he was lying, and then sterilize the whole theater for the next case list. So these are all the precautions that we have to take care of. And apart from the anesthesia challenges that we face when he comes for a surgery, is there any other role of anesthetist in treating the HIV patient? Dr. Ruby, did you mention anything about that?
Sir.
You have to say about they can be coming with a critical illness to the ICU. Okay, So they can come to that, or they can develop chronic pain and come for treatment for chronic pain or severe pain syndromes. And one word about obstetric patient coming with the HIV infection. So that vertical transmission from the mother to the baby is also a possibility because of the amniotic fluid and other things through which the virus can infect the child. So many physicians do not prefer not to allow normal vaginal delivery because it will take a long time and the opportunity, the chances of infection are more high. So they may seek for a operative delivery. So there you can use your routine spinal. There is no contraindication, but you must watch for post-spinal headache in these patients. It may be very troublesome, and all precautions to avoid that post-spinal headache must be taken in these patients with adequate hydration and a smaller needle, minimal puncturing, and bed rest at least for 24 hours to prevent CSF leak. All that should be taken care of. Okay. So otherwise, your presentation was quite good. I'll just share my slides to make a visual impression on that for the sake of those who have been just listening.